Good afternoon, everyone. My name is Stephanie Thomas, and I'm the chair of the newly formed AYA Hemonc Special Interest Group through ASPHO. And I have the pleasure of moderating the webinar entitled Addressing Sexual Health in Adolescent and Young Adult Patients with Cancer and Blood Disorders for the American Society of Pediatric Hematology Oncology. I have a few housekeeping items before we get started. Please note that all participants have been muted for the presentation this afternoon, and I would like to direct your attention to the chat room on your screen. Please use this chat room to ask any questions, which I will direct to the speakers at the end of our presentation. You can also use this area to let me know about any AV issues or technical difficulties that you are having during the presentation. We are very excited to be discussing this topic with you all today. Sexual health is such an important and extensive topic. Unfortunately, discussing fertility preservation is outside the scope of this talk. Our speakers today are Dr. Sharon Bobar and Dr. Natasha Frederick. Dr. Bobar is a senior psychologist at the Dana-Farber Cancer Institute and assistant professor in the Department of Psychiatry at Harvard Medical School. She is the founding director of the Sexual Health Program at the Dana-Farber. Dr. Bober's research interests focus on cancer survivorship and sexual health. Dr. Frederick is a practicing pediatric hematologist oncologist and assistant professor of clinical pediatrics at Connecticut Children's Medical Center, where she serves as the director of the Comprehensive Fertility and Sexual Health Team and co-director of the AYA program. Additionally, she is a founding member of the Sexual Health Task Force and the Children's Oncology Group AYA Committee. Dr. Frederick will be speaking with you all first today. Thank you all.
Hello, everyone. My name is Natasha Frederick, and I am very happy to be here today to talk to you about a subject that's near and dear to my heart. So to begin, so as Stephanie already introduced, we're going to be talking about sexual health in adolescent and young adult patients with cancer and blood disorders. And again, just to emphasize, the focus is on sexual health today and not on fertility and fertility preservation. And our objectives with today's presentation, I apologize, having some difficulties with moving the slides. There we go. There seems to be a little bit of a lag. Okay, so our objectives include describing the importance of sexual health communication in AYA cancer patients and survivors, developing strategies for discussing sexual health with AYA patients and survivors, and identifying specific resources and referrals to support AYA's reporting problems with sexual function. So to begin, we want to start with, why do adolescent and young adults need us to talk about sexual health? So as a brief overview, for many who are very invested in the AYA oncology population, this chart is not surprising. We know that there are nearly 70,000 AYA patients diagnosed with cancer in the United States each year. And for this number, we're talking about ages 15 through 39. And they make up about 7% of total new diagnoses in the United States. However, unfortunately, what we do know is that improvements in the survival rates and quality of life outcomes lag behind those of children and older adults, as demonstrated by the yellow bars in this SEER data plot that you can see here. Now, why is this? There are multiple reasons that contribute to this, and these include tumor and host biology, treatment responses, poor participation in clinical trials, developmental and life stage differences, and this population also has very distinct psychosocial needs. And to think about that, to help put that into context, we think about adolescent development. Now, adolescent development is a very tumultuous stage. There's a lot going on for young people, especially for the younger end of the AYA spectrum. This includes identity formation, including sexual identity formation, body image, intimate and emotional relationships. They're starting to date, explore their sexuality. There's the whole development of sexual and reproductive health, so thinking about sexual function, contraception, fertility. This population, they're starting to express their independence and separate from their parents, and they're also engaged in independent decision-making about future goals. So what do we know about sex in AYAs? So we know that healthy AYAs commonly engage in risky health behaviors, including risky sexual health behaviors, as part of normal development. And we know that nearly half of high school students in the United States had ever had sexual intercourse, with only 59% reporting condom use during their last sexual intercourse. So that's a pretty startling statistic or number right there. And prior research indicates that adolescents with chronic disease are at increased risk for engaging in risky behaviors compared to their age-matched peers. So we are just starting to learn more about how a cancer diagnosis may impact AYA sexual health during cancer. And given that the average age of sexual debut in the U.S. is 16, many AYA oncology patients have likely engaged in sexual behaviors prior to diagnosis. And we know I do want to emphasize that there is limited research out there in helping us figure out what sexual activity is taking place for our patients who are on treatment and in survivorship, but there is some data out there. We do know that survivors of early childhood cancer engage in risky behaviors, including sexual behaviors at rates equivalent to controls. We know that AYAs remain sexually active during cancer treatment, and we know that AYAs with cancer use contraception less often than their healthy peers. As part of work done by Dr. Abby Rosenberg in Seattle, she had a group of adolescent and young adult patients, and as part of some information that she was collecting on them, which is illustrated in this chart to the right, she demonstrated that patients, as you can see here, they were dating at diagnosis, 3 to 6 months later, still the same percentage dating. There was you could see that patients continue to be sexually active during treatment. Noticeably, you can see that they've had their sexual debut during treatment. So this information emphasizes the need to start to have these conversations with our patients. And so in a study by Zebrak and colleagues surveying 210 AYAs, they found that about more than 50% of respondents reported a need for counseling about sexual health. And of those, 82% reported that this issue was not adequately addressed during care. And more recent studies support this finding. So we know that AYAs consistently indicate the need for improved communication on sexual and reproductive health issues. We know that oncology providers are often underestimate the relevance of psychosexual issues among AYA patients with cancer. And they can tend to forget to include sexual and reproductive health conversations as part of an ongoing assessment through disease treatment and survivorship. And we also know, and this is key, is that adolescents and young adults are generally uncomfortable initiating these conversations, and they wish for their providers to start these conversations. So what do AYA patients say? So in speaking directly with AYAs, we do know that they don't discuss sexual health with our oncology providers. And some quotes from some work that we've done are illustrated here. So one shared, no, they just wanted to make sure I got my period and grew some boobs. They never talked about sex at all. Another shared, I think you'd ask me if I was having sex and if I used protection, and I'd say yes, but I never talked more in depth about it. However, we do know that AYAs want us to talk about sexual health. One shared, I really wish she had talked about it more to me. To just feel like it kind of got dropped off because there were other things going on, but that's important to me. It's something that's normal. It should be talked about and spoken about like any other healthy body issue. And I kind of wish she brought it up to say, like, hey, this could be related to your cancer treatment. If you want to talk about it, we can. I kind of never knew it was in the realm of things I was allowed to talk about to her. So just to briefly touch upon, why do adolescent and young adults have problems with sexual health, and how does the cancer diagnosis put them at increased risk for experiencing some of these issues? And as you can imagine, it could be a wide variety of factors that contribute to this. Some of it comes down to developmental, their age of diagnosis, when they're trying to reach these developmental milestones. Those can all be hindered by a cancer diagnosis. There can be interpersonal components, fear of intimacy, lack of communication with romantic partners. There can be social and cultural barriers that play a role in their sexual development, and of course psychological, going through a cancer diagnosis and into survivorship, issues with depression, anxiety, body image, self-efficacy, negative thinking. All of these things can play a role. And then there's the physical component, hormonal changes, structural damage, disfigurement, pain, fertility, fatigue. All of these things can play an instrumental role in sexual function. And then, of course, medical team assumptions. If we are assuming that our patients are too sick to have sex and we're not bringing it up, and they're not bringing it up, we're missing out on opportunities to provide appropriate anticipatory guidance. And finally, we know that sexual function impacts quality of life, and this is another reason why we need to be talking about it. Sexual health and fertility are topic areas that are deemed most important by AYAs. And about 30% of AYAs in survivorship report problems with sexual dysfunction. That's a pretty high number. And 20% report sexual limitations due to cancer. And we also know that sexual dysfunction does not improve with time. It doesn't go away if it's not addressed. There's a study recently published by Dr. Zebrack who showed that more than 50% of patients reported ongoing problems with sexual function 2 years out from diagnosis. So how do we start these conversations? So first, the question I often get asked is, are there guidelines? And it's a complicated answer because, yes, there are guidelines, but they're not very specific. But they are there. So the American Academy of Pediatrics recommends that pediatricians provide confidential time during a visit to discuss sexuality, sexual health promotion, and risk reduction. And the American Academy of Pediatrics and the Society for Adolescent Health and Medicine support adolescents' universal access to receipt of sexual and reproductive health care. The National Comprehensive Cancer Network, their guidelines within the AYA recommendations include a statement that we should be providing education about sexual health, including prevention of pregnancy and sexually transmitted infections, and that fertility preservation as well as sexual health and function should be an essential part in the management of AYAs with cancer who are at any risk for infertility due to cancer treatment. And finally, ASPHO. They have a statement out that says it is recommended that there be a discussion with the patient initiated by a member of the healthcare team regarding sexual health and dysfunction resulting from cancer or its treatment. Psychosocial and or psychosexual counseling should be offered to all patients with cancer, aiming to improve sexual response, body image, intimacy and relationship issues, and overall sexual functioning and satisfaction. So why do AYAs want information on sexual health from oncology clinicians? And they've told us for several different reasons, but 3 key reasons that they've highlighted included for the purposes of general education, one shared because teens have all these different issues with going through chemotherapy and may have different questions which may not be covered in class. And this individual is referring to general sex health education at school. They also encounter actual sexual health problems during cancer treatment. One shared, I struggled with sexual health questions through my treatment. I think that just overall more education would have put me, or maybe caused a little less stress in my life. And then also if they want to know about potential late effects. One shared, I think it's important to know what's going on and how cancer is going to affect me in the future. I'd just rather know everything that might affect me. So how do AYAs want this information? Both in research that's been done by our group and through multiple others in the field of adolescent medicine have explored this question. And several themes keep coming up repeatedly. And these include direct communication from their clinicians. They want the clinicians to initiate these conversations. They want this to be an ongoing conversation, meaning it's not a one-time discussion and then that's it. It needs to be something that's brought up on a regular basis. They emphasize the need to provide time alone with the clinician. So this means taking parents and other family members out of the room. And they want us to be able to normalize the conversation, phrasing things in a way so that they know that we're not just picking them out to be talking about this issue, that this is something we do on a regular basis with all of our patients. And there's also a strong need to individualize these conversations, and I'll talk about that in a minute. And so we've done some research looking at clinician barriers. So why do clinicians not feel comfortable talking about sexual health? Again, this is a very small qualitative study in which we interviewed 22 oncology clinicians across 7 pediatric academic institutions. And the purpose of the study was more to start to develop an understanding of what the barriers are. And there are likely others that are not illustrated here. But two key barriers that were noted included lack of knowledge in terms of how to start these conversations and then what to say to patients, especially if problems are identified, and also clinician discomfort. So how do we start the conversation? So first we need to create a safe and appropriate environment. And this is a perfect example up here. This is an example of one of our outpatient clinic rooms here in Connecticut. And one time I had to have a conversation with a 17-year-old young man about sexual health while he was sitting on the dinosaur. And I would argue that is not the most appropriate environment for that conversation with a patient. Additionally, as I mentioned before, it is really important to give patients time alone without parents and other adults or family members in the room. We need to respect confidentiality and making sure that you are very clear at the start of the conversation with the patient what you will keep confidential and what you would be required to share with parents or family members. And then individualizing the conversation. So this means taking into consideration the patient's age, developmental stage, gender identity, sexual orientation, sexual activity or level of interest, and disease type in their treatment. And of course, in the beginning, this is information that you're going to work on gathering. So what I'm going to talk with you about today is a communication framework to help assist you in having these conversations. I do want to emphasize that this is one model for how to do this, but there are a variety of different ways, and I'll mention a few of those as well. And really the most important thing is picking something that works best for you. So the 5A's communication framework originates from work focusing on smoking cessation, and it was later adapted to speaking for young adult patients with cancer regarding sexual and reproductive health. And so for the first part, the first thing you want to do is ask. You want to introduce the topic of sexual health and ask the patient for permission to proceed with the conversation. And this is really key because the patient may not be ready for this, and that's okay. You can bring it up at the next visit. But you really want to give them some agency and some ownership about when they can talk about something that's fairly personal. And an example of doing this, Many AYAs worry about how cancer will affect dating and relationships. I would like to take some time today to talk about this. Is that okay with you? Next is advice. And this is where you provide a brief overview on a specific sexual health topic. This doesn't mean you're going to go through puberty development, contraception, safe sex practices, sexual. You're not going to do all of this at once. You're going to pick something that would be most relevant to your patient and start there. And a way to introduce this. While sexual and romantic relationships may still continue or develop during cancer therapy, there are a few things that are important for you to know. And then you could talk a little bit about how it's important to take extra precautions when you're neutropenic, or there are a variety of different things, and we can address some of those later on when we have some time to talk. Next is assess. So at this point, you're going to ask some questions of the patient to learn a little bit more about them and where they're at and what their interests, needs, or questions are. And before you start jumping into those questions, I will usually start by saying something like, the following questions are personal. However, I ask them so that I may have the best understanding of your current health and to provide you with information that you need to keep yourself as healthy as possible during treatment. And then you can go through and ask them about their own sexual health, some more specific questions. And then depending on what you talk about, the next step is assist. And this is providing brief counseling based on the conversation assessment. So say the patient tells you that they're sexually active, they have one partner, and they only use contraception sometimes. So here, this is where you're going to talk about the importance of using contraception. And you can give appropriate handouts, pamphlets, website links, etc., and also make referrals as necessary. So say you have a 21-year-old female who went through Ewing sarcoma treatment when she was in her early teens, and now she's in premature ovarian failure. She's having hot flashes, vaginal dryness, and so sex is really painful for her. This is where you're going to work with a team that you cultivate at your own institution or location and identify who she can go see to help with that. And Sharon's going to talk a little bit more about how we address some of these issues with sexual function. And then finally, arranging follow-up. And this is scheduling follow-up, a follow-up visit to return and talk about the problems or concerns. And again, I emphasize it's really on you as the clinician to initiate the conversation. As I said, there are multiple models for doing this. Another well-known model is the extended implicit model, which includes asking for permission, providing limited information, giving some specific suggestions, and then providing treatment. And there's also the better model. And you'll notice when you look through these that they all have the similar tenets to structuring the conversation. I've provided here some additional resources for you. I highly encourage you to take some time to look at these. These are key references suggested by the American Academy of Pediatrics and sponsored by the Adolescent Health Commission. And these include references from the National Coalition for Sexual Health and Physicians for Reproductive Health. And for those of you that would like actual examples of how to structure these conversations or see other people doing them in real time, there's some great videos here to watch as well. So in summary, we know that AYAs want oncology clinicians to discuss sexual and reproductive health throughout cancer care. They have specific recommendations to us on how to do this, initiating the conversation, offering time alone, making it normal, engaging in ongoing conversation, individualizing to the patient, and directly communicating with the AYA. And I always emphasize that the most important thing that you can do is ask. So a couple challenges that we can address a little bit later or talk in more detail, but I know tend to be things that come up quite frequently when talking about this. There really are a paucity of guidelines for specific recommendations. People ask me all the time, well, at what ANC or what platelet count is it safe for a patient to have sexual or engage in sexual activity? And that's a a really difficult question to answer because it's going to depend on the patient and putting their clinical context together. It's just like a patient who is suffering from depression going through treatment. There's no one set modality that's used to address that issue. You need to take the whole patient into consideration. And there's also a need for more quantitative data to support current clinician communication barriers and potential education strategies. So now with that, I'm going to turn it over to Sharon Bober to talk more about AYAs and sexual dysfunction.
Thanks, Natasha. It's a pleasure to be here with everyone today. And to, just clarify again, talking about this is so important, largely because this really is like the elephant in the room for so many of our adolescent and young adult patients. And I think it's important also taking a step back when we start to think about treatment and intervention and what this actually means when we bring up the topic. It's really important to clarify for ourselves and for our patients that normal means really a wide and varied range of function, and that what is most important is that you need to identify what is important to the patient. And I think the key point is that if we bring up the topic with our AYA patients and we get a sense that they are either distressed or bothered in some way by something that has changed or different, then that's our cue that it's a problem that needs to be addressed. So rather than coming at this from a priori perspective of what is, quote, normal, we're really coming from the perspective that if there is any worry or distress or bother, then it means it needs to be addressed. Taking some time to think about what sexual recovery looks like or sexual rehabilitation, I think it's useful just to sort of clarify that, sexual function and sexual problems related to cancer are really sort of at the nexus between physical and psychological and interpersonal aspects of function. And so from that point of view, taking a biopsychosocial approach to recovery is really important. Understanding where there is distress or dysfunction, whether it's something physical, whether it's something psychological, often it might be both, how this is implicated in terms of interpersonal relationships, or if there's a social or cultural overlay. It's really important to sort of take that larger perspective when it comes to intervention. Again, as Natasha alluded to, also need to take into perspective that folks are on a kind of changing landscape when it comes to development, and appreciating that, whether that's in terms of identity or sexual development, whether that's specifically around the sort of psychological changes that take place in terms of moving from a place towards sort of greater individuation or separation, especially as we know in the context of AYA cancer, when often parents are in the room and involved in treatment, and there is a kind of a tug between that sort of pull for individuation and connection with parents. It can be complicated in terms of what this means for sexual function. And again, also recognizing that for adolescents and young adults without cancer, this is a landscape that is fluid and that we need to be sensitive to that. So in terms of thinking about risk factors, I think it's important just for all of us to have a kind of a perspective that we know when often folks are single, young adults, or and not partnered, it may be that there's something that they're very worried about, and we shouldn't write this off as something that's not relevant. People that are, struggling with fatigue or physical problems, feeling of lack of general overall health and well-being are more likely to also have concerns about sexual function. Anybody who has been dealing with any kind of depression or distress or anxiety is often more likely to also have concerns about sexual function. And that thinking more about our survivors, often we sort of tend to think, well, let's see how things play out and if they'll get better on their own. But certainly if sexual function, sexual activity has not returned to normal or to baseline, or people still have concerns by certainly well within 9 to 12 months after treatment ends, then we really need to think about intervention. So when we think about the most common problems that we see, we can really sort of categorize those in a way in terms of thinking about problems related related to sexual desire or motivation. Often people talk about having low desire or no desire, reduced motivation, and concerns around decreased body image and self-esteem. And then we also can think about the range of issues around sexual response. So whether that's issues around arousal, orgasm, erectile function for men, any kind of ejaculatory issues, or pain or discomfort for women. So I want to talk a little bit about sort of the basic kind of treatments that we sort of think of for those issues. And again, starting with how we start, where to start, questions as Natasha alluded to, starting with basic kinds of questions. Many of my patients with this kind of treatment have concern about sexual function. Is there something bothering you, or anything that you'd like to ask me about? And again, referring back to the frameworks of communication that Natasha offered, can be very helpful. If people are interested in using a checklist or a systematic approach that goes beyond a sort of a basic kind of question where we're asking about distress or concern, I want to just take note that there are a number of, I think, very user-friendly kinds of instruments available. There's just a couple of examples I want to share with you. One is a sexual symptom checklist for women after cancer. This was adapted from a sort of a general sexual function checklist for sort of normal general population, which we adapted for folks after cancer treatment. And you can see it's really more of a kind of a sort of a short guide, starting with, are you satisfied with sexual function? Do you have any concerns about vaginal health? And if the answer is people are either not satisfied or have any concerns, going on to ask a kind of, again, a quick but thorough checklist, everything from loss of interest and decreased sensation to vaginal pain or vulvar discomfort not during sex. So again, not only relevant for folks that are partnered or having sexual activity with someone else. Similarly, short checklist for adolescent boys and men around erectile dysfunction. Again, short 5 questions, but sort of gives a quick snapshot as to whether someone is having mild, moderate, or more severe erectile dysfunction. So getting back to what we then do about this and what actual sexual rehabilitation looks like, again, I just wanted to sort of show the scheme where we sort of break down what it is that we actually look at. So when it comes to physical function, we're thinking about sexual rehabilitation very much in the context of overall general health. We're thinking about psychological health and mental well-being, very specifically not just about affect and emotion, but also being able to look at how people think and the sort of automatic negative thoughts that often are connected to issues around sexual dysfunction and issues around motivation. Thinking about the sort of social interpersonal aspects of sexual function, we really not only ask about kind of current function, but past function and expectations for future. This is important because if kind of somebody is coming into this experience where they have already had either certainly a previous trauma experience or just previous experience where they have been distressed in some way, that is not just about cancer, but that's something that we're going to have to address in the context of rehabilitation. And also, again, taking into account that we are all living in a kind of a culture, a kind of a larger social cultural context that may have norms, taboos, religious beliefs, values that we need to take into consideration when we're doing intervention. I think it's important to appreciate that we sort of start with the body, sort of overall health and well-being. Really important when people are dealing with pain or discomfort. We need to be able to address those mechanics first. We need to also be able to sort of note that people need to feel a sort of overall sense of health and well-being in order to feel sexually functional. So if people are not getting enough sleep or exercise, if people are feeling that if people have other relevant medical factors, neuropathies, mobility issues, they really need to be addressed as part of moving forward with sexual rehab. Want to talk a little bit about girls and women because the number one issue that we see it is sort of distressing and connected to sexual dysfunction really has to do with a disruption in ovarian function. And that may be caused from chemotherapy, that may come from surgery, that may be from radiation, variety of treatments, ovarian suppression. But when we know that we disrupt ovarian function, there is profound impact on vaginal and vulvar health. So certainly in terms of vaginal changes, this extends to sort of loss of blood flow, loss of elasticity, lubrication that is directly connected with what's going to be pain with or without with sexual activity, that may be discomfort, riding a bicycle that may be itching, chafing, burning sensation. Certainly that's the case in terms of the vulvar changes, loss of collagen and fatty tissue. And we know that about half of our testosterone is lost when our ovaries are no longer functioning. So again, implications for issues around desire. But this is something that we don't always think about when we're talking with our young female patients, and that we really need to appreciate with them that they need to be able to think about vaginal health as much as sexual health. So although these are connected, they are not the same thing. This is a slide that we will show patients and specifically talk about the fact that when you have a loss of moisture and stretch and blood flow, you're going to have discomfort. There may well be pain. And when that happens in terms of sexual activity, there is going to be a desire problem that is connected to that because there's quickly a pain cycle. Vaginal sort of pelvic floor muscles get very tight, automatically start to clench in anticipation of any kind of discomfort that may well extend to just pain with pelvic exam, not with sexual activity. So from that point of view, young women and girls need to know about taking care of vaginal health, improving vaginal health, and recognizing that that kind of vaginal atrophy secondary to estrogen depletion does not self-resolve. It tends to worsen over time, and that is not something that we can sort of just wait and see what happens. So what that means is that we need to do something about it, specifically give you a sense of the kind of education information that adolescents and young women need. They may well need to learn about the pelvic floor. They may well need to learn how to relax pelvic floor muscles. That may involve a course of working with pelvic floor physical therapist, using a vaginal dilator. Young girls or young women who have any pelvic radiation are going to have significant atrophy, will need to mechanically stretch that tissue so that not just sexual activity, but again, a GYN exam is comfortable. So using dilators, learning that they need to replace moisture with a vaginal moisturizer that is separate from a lubricant. This is the kind of information that everybody needs to get if they've had, for example, pelvic radiation or if they've had estrogen depletion. And that can be given also by way of teaching sheets. So not necessarily intensive intervention, but really basic information that everybody needs to have. Similarly, I want to talk a little bit about ED, which is sort of common problem for young men. That is something which we often see as both connected to both physical and psychological factors. Certainly hormone levels are important. We need to look at any kind of medication side effects. We also know that young men often feel enormously anxious or worried or ashamed. Young men after, for example, testicular cancer, may be feeling very uncomfortable or worried about, body image, loss of body integrity if they've had orchiectomy. Certainly, we also know that unpartnered survivors, young men who are single, will often report worse satisfaction with erectile and orgasm because they feel quite self-conscious about it, even more so than those that are partnered. So, what do we do with young men who are struggling with ED? Well, first of all, I think it's important, especially in this day and age, that we set realistic expectations. What is actually normal? What do we actually expect? What is different than pornography, which is often, unfortunately, how young men sort of gauge what is normal. And then we need to sort of have a plan for managing ED. So, in addition to the sort of psychological factors, sort of physically, what is the kind of systematic way that we approach therapy, starting with certainly any kinds of causes that are sort of lifestyle or sort of medication related. We need to address those first. Often we will start with, first line, a PDE5 inhibitor, and that can be very helpful. But there also is important for young men to know that there are additional options if we need them. So guys can use a vacuum erection device, which is a mechanical device that is not pharmacologic. It is also possible that young men can use penile injection therapy, which is very effective if necessary, and if, for example, PDE5 inhibitors do not work. But there really are a number of options, and we also extend this to say that for young men who are partnered and who are struggling, it's often helpful to work with the young men in the context of a couple, right, in order to be able to sort of really optimize sexual rehabilitation. So similarly for guys, very important for young men to have, the basic information for what they need in terms of instructions and coaching around use of all of these kinds of devices or pharmacologic options. We also know that mindfulness-based stress reduction and use of exercises like sensate focus is incredibly helpful in terms of reducing stress, taking pressure off, giving young men a kind of really sort of a roadmap for how to feel good in their body and for them to sort of know that they can address sexual dysfunction without feeling damaged. And again, using couples counseling or individual counseling is necessary. Also want to just sort of speak to the notion that it is very common that we see body changes and body image issues, and I want to just say that sometimes these are obvious, and whether that's an ostomy or surgical reconstruction, really important to recognize that sometimes these things are not obvious. Somebody may look well, look healthy, but really be struggling because there are less visible issues that really impact body. So whether that's loss of sensation or pain or fatigue, people often have a sense of not having a sense of confidence or trust in their body, and being able to sort of take a counseling approach where we really sort of allow people to, first of all, figure out how they can be fully in their body and relax without feeling hypervigilant or anxious. That's important, and it's often not obvious when you've gone through invasive cancer treatment. So being able to ask about body image, knowing that what you see may not be what you get, and that's why it's also very important to ask. I think the role of counseling is particularly important for AYAs who are struggling with all of the kind of negative automatic thoughts that they may have that really drive negative emotion. Recognizing that people can become aware of those thoughts. We can use sort of cognitive behavioral therapy. We can use mindfulness-based cognitive therapy in order to promote not just compassion for oneself, but really a capacity to shift from these sort of automatic negative thoughts to something that is more neutral. We can allow people to sort of increase capacity for creating a kind of a more judging, sort of a non-judgmental awareness rather than sort of a very judgmental awareness, which is often what people struggle with. And I also think all of this needs to be done in the context of increasing autonomy and competence and choice for our AYAs who often really feel like they haven't had a lot of choice and haven't had a lot of options when they've gone through sort of invasive treatment. So that can really be an important antidote as we sort of think about what sexual sort of counseling and rehabilitation looks like. So I would say in terms of what this sort of means for clinical practice, I think it's really important really at two levels. One, for practitioners to identify what their own goals are. Does that mean I need to figure out just sort of what my own biases or areas of discomfort are? What do I need to know in terms of my own blind spots? Am I sort of not aware that I'm asking about some of this because I think somebody either is not sexually active or is too old or too young? Just committing oneself to figuring out kind of what the goals are to increase one's own awareness and to commit to getting the kind of education or consultation as needed. And then I think it's also really important to figure out what the systemic changes are that are necessary. So figuring out, how do we add sexual health into our basic review of systems? What does this mean in terms of the time and the process necessary to do that? And how do I identify and build just a very solid referral or resource network, because I'm not going to ask about these questions if I don't have somewhere to send people. So identifying again, who is the team? Who is the gynecologist or urologist or endocrinologist that I would send someone to? Who's the counselor I could send someone to? Do we have, for example, a pelvic physical floor therapist that we can identify, and if we don't, can I use professional organizations to help identify some of these folks? And the answer is indeed you do. Certainly, International Society for Sexual Medicine, Sexual Health Society for Women, North American Menopause Society, STAR, Cancer Sex Network is also a great organization that I'm a part of that's just focused on female sexuality after cancer. All have opportunities to identify professionals by location and area of expertise. And then also figuring out just who the go-to person is on my team to bring up these issues if it's not something that I'm going to do myself. With that, I will close, and I think we might have some questions, but great to be with you all today. Thank you.
Thank you, Dr. Frederick and Dr. Bober. I want to remind the participants to use the chat room to raise questions or make comments. The recording will be available on the ASPHO website in the next few days. So a few questions that have already been in the chat area. For research studies, we often need documentation of safe sex and reproductive health for a new diagnosis. This includes talking about many aspects of sex and reproductive health. How would you advise talking about these all at once versus spacing out the conversation?
Well, I think that's a great question, and I think usually for the purpose, as someone who consents many patients to research studies, I think for this you just have to go through, because usually they're asking for very specific information. Again, thinking about the things that I had mentioned earlier in the presentation, for some of this stuff, I make a habit of always asking parents and family to step out of the room, whether I'm going to talk about sexual health or not, just to give that autonomy to the patient, especially my adolescent and young adult patients. And usually for those, when you're going through things, I will say, you know what, for this research study, there are some pieces of information that we need to cover very quickly. I think this is also something that, in terms of screening, that's very standard practice in adolescent medicine. So, for example, asking, Siri's trying to chime in at the same time. So I think asking, are you currently in a relationship? Are you interested in boys, girls, or men, women, both? Are you dating anybody? Are you physically intimate? Kind of starting with more general questions and then working your way into the specifics. Sharon, I don't know if you have other things that you want to add.
Yeah, no, I mean, I guess the question about, how do you talk about it all at once or spacing it out? I think I would also just want to say that, although these things are related, they're not all the same thing, right? So being able to have a conversation about safe sex and reproductive health, I think each of them obviously important. But I also would just say that being able to sort of maybe say to the patient that they're really sort of different topics that are connected but that are not the same, and you want to make sure that you have time to address. I think it's important. I guess my thought is that often safe sex and reproductive health get talked about, but sexual function does not. And so I do think it's important. I don't think it actually matters whether you talk about them or you sort of bring them up at once or space them out. I think the thing that we're struck by is that often sexual function actually doesn't get talked about at all. There may be some touch on safe sex or reproductive health, but actually with the exclusion of sexual function. Would you agree, Natasha?
I do agree. And I think for this specific question in the context of getting information to consent for a research study, I think you can also be upfront too and say, you know what, we're going to talk about this a lot throughout treatment, and there'll be many opportunities for you to ask questions and for us to go over details. And right now, these are just some key quick questions and information that I need to collect for this purpose, but always making sure that your patient knows that they're going to have opportunities. You're going to create opportunities for them to bring have these conversations down the road.
Right, that's right, especially in that context, absolutely. Yep.
Thank you both. That leads really well into our next question. Each of you briefly touched on creating or having a team of providers who may be available for specific sexual health counseling. For females, it seems like a gynecologist would be a good fit. But what have you seen at some facilities in the way of male counseling? Do males get referred to a urologist simply for sexual health concerns, or are there other disciplines involved, such as psychology, nursing, social work, et cetera?
I think it's a good question. I would say that for males, couple of things. First of all, not all urologists, I should say, really work in sexual medicine. So, I think that it is important to identify if I do think it's important to have a urologist that you can send someone to, but I think you need to check that urologist is comfortable dealing with sexual dysfunction, because within the world of urology, some urologists do that and some urologists really don't or do not have a lot of expertise in that. So it's important to find a urologist who specifically feels comfortable dealing with erectile dysfunction. The other piece is that I think it's important to have an endocrinologist to deal with the issues around testosterone, if that's not something that you're going to do on your team, because often that's an issue that has to get addressed. And then I think that in terms of the counseling piece, it doesn't matter, whether it is a psychologist, whether it is a social worker. It's really more important that there is somebody who does counseling and is comfortable dealing with sexual health and is experienced with sexual health. And I don't think that is necessarily discipline specific, i.e. social work versus psychology, but that I do think it is important, especially for guys, because often there is such emphasis in this culture on only erectile dysfunction from a very mechanical point of view, with the assumption that it is just about take a Viagra or get an injection in order to have an erection. And we know that especially for our AYA patients, the issues are really not only just mechanical. It is just as important, if not more important, to be able to also address the issues around anxiety, self-consciousness, sense of shame or discomfort, and that I think it's really important to actually have somebody who can do the counseling piece in addition to endocrinology and urology.
Yeah, and I would just echo what Sharon said, and said that it's really about finding your tribe at your institution. So for male patients, I'm very fortunate that my social work team here is part of our group. All three social workers are part of the AYA team and are very invested in communicating and talking to patients about these issues, in addition to myself as one of the physicians in terms of leading those conversations. But we also partner. I have a specific point person in pediatric urology, a specific point person in adult urology. And I would even argue that you have to be careful with gynecology too, because I've met many women who've gone to gynecologists and they haven't really always they're not experienced with cancer and patients who've gone through cancer and some of the issues that they might face.
Yeah, and I do want to echo that about what Natasha just said, particularly around issues like, for example, around hormone replacement, use of vaginal estrogen or vaginal hormones. There is often enormous misunderstanding and sort of lack of appropriate information in general GYN if they are not sort of up on working with cancer survivors. So absolutely.
Yeah, and I'd also say, too, it's about finding people who want to work with you so that you can call them up and say, hey, I have this patient. Can you help me out? And I found a couple people, even here in Connecticut, who this may not have been what they were doing before I got here, but now they're interested, and they're interested in working with me and other people on our team to help address these issues.
Thank you both. I think that actually answers our next question, which was who do you recommend have these discussions with the AYAs, medical providers, nurses, psychologists, or who does this at your institution? And I think the team approach is really what we've been stressing and what's so important, and it doesn't have to be the same at every institution. It is who is comfortable having those conversations and developing a network. Would you agree with that?
I would agree with the caveat that as the oncologist on the team, just like we go through and talk about all the potential side effects of chemotherapy, we talk about doxorubicin and cardiomyopathy, and kind of go down through our checklist, I do think that it is our responsibility to talk about some of these issues as well. But I do think it varies in terms of how far you're going to go in the conversations in terms of addressing issues with sexual dysfunction. But I think it's on us to get the conversation started and then refer out and seek help from our colleagues as necessary. But it really, these conversations just need to happen, and it's about creating an approach at your institution that works well for you and identifying team members who are going to initiate the conversation.
Right. I would just sort of add to that I think as much as it is a team effort, it's also important not to have a diffusion of responsibility and assume that someone else on the team is doing it. Because I know that we've done, provider surveys where, everybody agrees that somebody should do it, but just should be somebody else. So I think it is important that, everybody, as much as it is sort of a team effort, that there is kind of clear delineation of responsibility in terms of who is going to have the conversation when. So there isn't a kind of assumption that it's getting done by somebody else.
Right, and I would argue too that as the clinician, I think very oftentimes as a pediatric hematologist oncologist, we take over as the primary care physician, especially when patients are going through treatment. So we need to be having these conversations just as patients would receive through their well child checks. We do need to ask if they're sexually active. We do need to provide counsel on contraception, safe sex practices, and those type of things. I think that very much is our responsibility. I think it's also if for people who are really uncomfortable having these conversations, if it's not you as the primary hemonc physician, if it's someone else, if it's the nurse practitioner or one of the nurses, but making sure you're closing the loop and someone is talking about it, not just assuming that other people are talking about it. Because more often than not, what we're learning from research with adolescent and young adults is these conversations are not happening.
So that is all the questions that were posed by the group on the call today. We have a couple more minutes, and there were some questions that were put in before, and so I was going to pose one of those that I hear a lot. And this person was asking about framing sexual health communication with adolescent minors in areas of the country where sexual health is not frequently discussed and discussions of sexuality in an extramarital context is culturally taboo. Do you have any ideas for how to address in those situations?
This is Sharon. I would say that being able to normalize discussion of sexual function as any other review of system, right? In terms of acknowledging that it is normal that people have changes in their body after they go through treatment. It is normal that people have common worries and concerns about sexual function. It does not need to be placed in the context necessarily of sexual activity, although you may well ask that, as Natasha said, in the context of kind of a general wellness type of visit with any AYA patient. But I think that it is also possible to, very much talk about sexual function in a kind of a more clinical, less loaded way, so that you're not necessarily running sort of against what might feel like a taboo. Can you say the question again about sort of the extramarital piece? I didn't quite get that stuff.
Just that there are areas of the country where discussing any type of sexual health in an extramarital context is taboo.
Oh, meaning that just the idea, acknowledging that people may be sexually sexually active if they're not before they're married. Right. Mm-hmm. Yeah, that's where I would say that, so for example, talking with, a young woman about vaginal health, is very helpful, for example, that she may, as opposed to sexual health, or to say lots of people have changes in vaginal health that is related to sexual health, but that's not only about whether you're sexually active. I think, for example, it's very important to be able to talk about the fact that it's important to take care of your whole body, including vaginal health, and that is not about sexual activity, right? That's about having a healthy body. So that might, that might be one way to go about it. Similarly, in terms of talking with young men about erectile function, whether, again, they're sexually active or not, I think is important because they may have concerns about that just in terms of how they're feeling about themselves, how they're feeling about whether their body is working the way that it used to or how they would hope it to. Natasha, do you want to add to that? Or is it?
No, I think that's pretty comprehensive. I mean, of course, in different situations and with different families, it's going to be a trickier conversation, but I don't think that's a reason not to have it. It's about figuring out within your community what's going to work so that you can have those conversations. And again, this is some of the emphasis on making it standard practice to have parents step out of the room with your adolescent and young adult patients. And again, this isn't just to talk about sexual health. There's so many other issues. In addition to just giving patients time to ask things that they might not want to ask in front of their parents.
I agree. And I guess I would also say, Amy, having a conversation with an adolescent young adult who is not married but may, and it may not feel that they want to talk about sexual activity if they're not married. On the other hand, if they want to be partnered one day or maybe thinking about being sexually active one day, they may have questions or concerns now that need to be addressed. So again, I don't think it's this. I think we can easily talk about this topic without promoting, sex outside of marriage. I actually don't think that necessarily has to be the case. I think it's very possible to talk about this in a much more sort of function-oriented way that's equally relevant to young people or adolescents or young adults, whether they are married or not.
Thank you both so much. I believe we're out of time. And just another quick announcement, this webinar was born out of the newly formed Adolescent and Young Adult Hematology Oncology Special Interest Group through ASPHO. So we hope that you'll join our SIG on the ASPHO website. And we also want to remind and encourage everyone to register for the annual ASPHO conference, which is May 1st through 4th, 2019 in New Orleans. We look forward to seeing you all there, and thank you all for joining us today.